part of this meeting and to give two brief overviews of our African Network and Registry for ART. And in my first presentation, I will be focusing on the data, and then in the second presentation, talk about the more practical and operational aspects of the registry and the network. These are my disclosures. And usually the acknowledgements are at the end, but in this case, I would like to start and to acknowledge with gratitude Professor Iman El-Gindi, who has organized and facilitated this meeting with great energy at short notice and with a lot of passion and personal endeavor. And we are very grateful for that. She has beautifully acknowledged already Dr. Raga Mansour, and I would like to join her in that. And I know Dr. Raga very well from the board of the International Committee Monitoring ART and understand that she's not currently in the country. I wish to pay special tribute to Professor Gamal Sarour, and thank you so much for being here this evening, and to congratulate him on being the newly elected president of the African Federation of Fertility Societies. Thank you so much to Professor Hassan El-Maghrabi, the president of EFRE, and also to the co-speaker, Professor Yacoub, from Egypt, but currently also at the King's College in the UK. Thank you to all of you. And then thank you to all the medical and laboratory directors, to the embryologists, and each and every participant that is giving your time this evening to be here with us. I would like to start this presentation with a quote by Melinda Gates. Data make the invisible visible. Data make the invisible visible. And we can see on this pie chart from the International Committee, already referred to by Professor Iman, how near to invisible Africa has been in the context of global assisted reproductive technology. We have seen that this slice of Africa, being 1%, has now recently increased in 2016 to 2%, but we are still a thin sliver. And the reason Africa is such a thin sliver is, of course, that to some extent there is still a scarcity of ART in Africa, but equally because we have been lacking the scientific data. And in comparison, this pie chart shows us the size of Africa that we should be in this pie chart if we were merely representative of the size of our population. And given the importance of Egypt in the context of Africa and the size of the Egyptian population, Egypt would make a substantial proportion of Africa in this context. So Africa is often described as a low resource setting, and low resources have many faces, but one of the faces of lacking resources is scientific data. And it therefore has been the mission of INARA, and I will talk a bit more about the vision in my next presentation, but it's been the mission of INARA to generate locally applicable scientific data regarding the outcomes of assisted reproductive technology. And I will now go straight into the most recent release of our data, which has been published in RBM Online. And I would like to point out that in the line of authors, there is also represented the leaders of the regional reproductive networks in Africa, Dr. Ernestine Gwetbel, who was then president of Giraffe, and Professor Oladapo Ashiru, who is the outgoing president of the AFFS. And for me, this speaks to a beautiful spirit of knowledge co-creation. In the map of Africa, we see the location of centers in orange that have shared their data and participated in this knowledge co-creation. And in total, there have been 73 centers from 18 countries in this period of 5 years. And in white, the location of centers from countries that have joined our network and registry, but that have not yet shared their data. And we are growing as we speak. Here I am showing you the overview of the over 150,000 cycles captured in the registry in this period of 5 years, as well as the effectiveness of our autologous cycles. And we can see that in Africa, we are practicing predominantly autologous fresh cycles, although Professor Iman has already spoken to the increasing trend of FET. And we can see on the right that the clinical pregnancy rates following fresh autologous transfer have remained relatively constant and very favorable, close to 40% between 2013 and 2017. When we look at our autologous FET cycles, we note an increase in the proportion of FET cycles, but for all of Africa, perhaps not yet that pronounced, from about 14 to 18% in this 5-year period. But what is very pronounced was the increase in the clinical pregnancy rates in this 5-year period, from 25.6% in 2013 to 36% in 2017. There is a richness of data in this report that I really encourage you to explore. But for the purpose of this presentation, I will condense this data richness into 3 key messages. ART utilization was low. Our women were relatively young, and the transfer of multiple embryos predominated. So let us take a brief look at each of those 3 messages. ART utilization, expressed as the number of cycles per million population in that year of reporting, is a very important outcome measure. And ICMAT has recently promulgated it as an indicator of access to infertility care. Already 2 decades ago, the European Society of Human Reproduction and Embryology estimated that we would need to treat 1,500 couples per million population per annum in order to meet the demand for infertility treatment. And this benchmark is derived from an evidence-based algorithm that starts with an infertility prevalence of about 10%. So our data create visibility around 2 important messages. 1, ART utilization was low in Africa, very low. And 2, nothing much changed in this period of 5 years. Our women were relatively young. Women undergoing fresh autologous transfer, both at the beginning and at the end of this 5-year period, over 50% were under the age of 35. And in the frozen cycle, the proportion of young women was even higher. Quite understandably, and as expected, there are differences in the clinical pregnancy rates when we compare younger and older women. And when we interpret our overall pregnancy rates and outcome of ART in Africa, we do need to keep the favorable age profile in mind. We can speculate why Africa may be so different in terms of the age profile to other regions. And I'm sure my co-speaker, Prof. Yaku, will emphasize that in the UK, the age profile will look very different. But we must also ask ourselves, where are our older women? We know that they are not in the oocyte donation data. In many countries, it's not practiced. But in all of Africa, less than 10% of our cycles were oocyte donation cycles. So where are the older women in Africa? And my 3rd key message is that during this 5-year period, the number of transfer of multiple embryos predominated, specifically 2 and 3 embryos in over 80% of our fresh autologous transfers. Single embryo transfer in the fresh cycles did not change much, just over 10% in 2013 and in 2017. But as already Professor Iman has alluded to, the transfer of 4 and more embryos is becoming increasingly uncommon and dropped by some 33% in this 5-year period. But interestingly, and so importantly, the increase in FET cycles with regards to SET was very significant. In FET cycles, SET increased from 11% to 22%. And that would suggest that embryo cryopreservation and single embryo transfer go hand in hand. The practice of transferring multiple embryos is underpinned by the belief that, at least in terms of the chance of success, in terms of clinical pregnancy rates, it is better to transfer 2 or 3 embryos rather than 1. But the question, is that true? So let us look at what the data tell us. And in this graph, I want you to look first exclusively at the orange bar, and just to explain that we are now turning from our retrospective summary data to a subset of data in this trend analysis, which is our cycle-based data from our software. So when we look at the cycle-based data only, which gives us this information, and we compare the orange graphs, then yes, when we compare all SETs with all the ETs, then the pregnancy rate with 2 embryos is substantially higher than with 1, 37 compared to 23%. But the story changes completely when we distinguish elective and non-elective single and dual embryo transfer. And we can see that elective and non-elective SET are completely different entities. The elective transfer of the single embryo with the availability of surplus embryos is associated with a superb clinical pregnancy rate of 43%, very comparable to the elective transfer of 2 embryos, but with a substantially lower risk of multiple pregnancies. And it is in contrast the non-elective transfer of the single embryo, the transfer of the only available embryo, that not surprisingly carries a lower or much lower prognosis with a pregnancy rate of 16%. And seeing that in many settings, the SET is non-elective, this is what pulls down the pregnancy rate in the orange bars. So we now have locally applicable scientific data to counsel our patients, as Professor Iman has alluded to, and to use our scientific data to inform our choices in our clinical practice. And with this very brief overview on our latest recent release of data, I want to conclude this part of the presentation by saying that the African Network and Registry for ART has increased the visibility of ART in Africa by generating locally applicable real-life scientific data. Of course, as we answer some questions, new ones arise. And one of the questions we need to answer is the outcome of our pregnancies. We need more information about our neonates. But NARA is very committed to continue generating these data, to finding new questions, to answering new questions, expanding the quality and the scope of our data, and to do so in a spirit of collaboration with all the participating centers. And it is with that that I very gratefully and joyfully acknowledge all the participating centers that shared their data, participated in the knowledge co-creation, and that were named in the publication in RVM Online, as well as the network partner and sponsors. I thank you for the attention of this first presentation, and that concludes my presentation. Thank you.
Thank you, Dr. Silke, for marvelous presentation, very useful to counsel our patients with, and to all of us. I think this presentation is very useful in our practice for clinician and for patients. Thank you so much. Now the floor is open for questions. Raghda?
أيوة يا دكتور.